Okay, so we're now recording, which is great. Okay, so where did this metric come from? So the time to antibiotic metric came really from critically ill adults. So it was patients in the ICU that were usually in septic shock, and showing that there was a survival benefit in getting antibiotics to those patients in a timely fashion. However, it kind of got extrapolated to adults with cancer, saying, well, if it's true for them, it's important for them, and then get extrapolated to pediatric cancer really with almost no data. To say, well, if it's true for adult with cancer, it should be true for pediatric cancer. And there is some common sense in this that, there are patients that are sitting in the ER in septic shock in the waiting rooms that were never seen, and then would, decompensate before people would see them, or people would not have their Imla cream over their port and would want to get accessed and said, well, can you just wait 45 minutes before we assess you? In those cases, those were not good reasons to delay. But I'm going to argue that some delays may be worth it. And in particular, the time it takes to obtain a CBC result in a blood culture could help better management. So additional history. So because setting a clock is really easy. So if you want to say that, okay, there's a 60-minute metric, that if you're under 60 minutes, it's success, and if you're over 60 minutes, it's failure, it's very easy to do a QI project for this. So you say, okay, we set a clock, and if you're over or above, it's the difference between success and failure. And in fact, there were multiple publications, probably nearly 30, that came out that just showed that people's papers would say in the introduction, as we know, time to antibiotics is really important, usually with no reference. And then they would go down to say, our time was this, we did this, and our time became this, success, and not actually talk about any of the clinical outcomes for it. And so as a result, then, we wouldn't really find out if it worked. And in fact, in 2011, it became a metric for U.S. News and World Report pediatric cancer rankings. And so if you didn't have 95% compliance on it, then you would get dinged on the ranking of your program. And so then that would cause everyone to move to implementation, because nobody wanted to risk the ranking of their program. But it raises some questions. Does doing this metric lead to optimal decision making? It's costly and time intensive. A lot of times people had to hire nurses and nursing teams to monitor this. Is it worth the cost? And really, does it lead to improved outcomes? So how to be compliant? So people found pretty quickly that addressing those things of like quick assessment is pretty easy to do. But what they found is if you really want to get 95% compliance, you end up not waiting on CBC results to give antibiotics. But the reason why I don't think this is a great option is that I'm going to make a pretty compelling argument that everyone may not need empiric antibiotics. And so you're giving a lot of unnecessary antibiotics if you do that. Every time you give antibiotics, you're impacting the microbiome. You're also selecting for resistant organisms, which, particularly if you look in some countries, have become a major problem and are at risk to become a problem here. You can also, if you give it before a blood culture is drawn, you can pre-treat your culture and actually not get to the answer. The other problem is that this metric isn't timed to appropriate antibiotic, it's timed to any antibiotic. And so this kind of leads everyone to give ceftriaxone, or 95% of the country to give ceftriaxone. But really, this isn't an appropriate antibiotic for severe neutropenia, because actually when you look at the data, it only covers about 45% of isolates. So 55% of the time that people actually have a bacterial infection you're worried about, you're not covering it with the antibiotic you're giving. It also leads to a lot of programs that stack cefepime. So a lot of times they'll give a dose of either ceftriaxone and then they find out the counts and then they'll give them cefepime right after it, or they give a dose of cefepime and then when they find out they're non-neutropenic, give ceftriaxone right after it. But giving two cephalosporins on top of each other, it does actually have toxicity. It definitely increases hemolysis and a lot of other problems, and it's really not good care. And then there were even some programs that were giving intramuscular ceftriaxone without a blood culture at 55 minutes just to meet the metric. And this is actually with standard of care at some top 5 institutions. So does time to antibiotics impact clinical outcomes? So I would say that the literature really had not been conclusive on it. They were mostly based on small studies that had some methodological concerns. And what a systematic review really uncovered, the reason why they said they weren't finding much is there's something called a triage bias. And what this is that patients that are sick tend to get antibiotics very quickly. So if you look like you're in septic shock, they don't wait 60 minutes, they just give them to you right away. To me, I actually think that's a good thing because you're recognizing the sick patients, but then it really says that the other patients doesn't really matter. But it shows that you do have to correct for that anytime you're going to do an analysis on it. So this led to a paper, The Impact of Time to Antibiotic Delivery in Pediatric Patients with Cancer Presenting with Febrile Neutropenia. It was actually done in collaboration with both Vanderbilt and Children's Hospital of Colorado. So Leonard Slatnik, who was a fellow here at the time, participated, as well as Jenna Demitis and Halden Scott on your PED side. And in order to answer this, we thought that you really needed a large cohort, and be multi-site. So we ended up pulling all febrile neutropenia episodes at Vanderbilt between 2007 and mid-2022. So that was 1,920 episodes. And then we got an ER data set from here that was 429 episodes. So we ended up with 2,349 episodes. We also thought it was important to have a time period before and after we really tried to start meeting the metric. And so at Vanderbilt, we didn't really target it until 2015 to try to get our rankings up. And so we have periods both before and after trying to do it, and wanted to look at multiple settings. So we looked at people that came in through the ER, people that came in from clinic, and people that were already inpatient at the time. And so we want to see, well, what clinical outcomes matter? So the things we came up with is a primary outcome, which is a major complication, which we thought, being admitted to the intensive care unit, needing vasopressors to support your blood pressure, being intubated, or having infection-related mortality as being the strongest things. And then we excluded from the main analysis those that were severely ill, and I'll talk about that group separately. And we wanted to look at multiple time points from presentation. So we looked at things that happened within 6 hours, within 24 hours, and with 7 days of presentation. For secondary analysis, we also looked at all-cause mortality, length of hospital stay, need for oxygen of any type, but we only got that in the Vanderbilt cohort, need for any bolus fluids within 24 hours, and the amount of bolus fluids needed within 24 hours. We looked at time to antibiotics versus the cut point of greater than or less than 60 minutes, which is the classic cutoff. But we also thought that if time to antibiotics really matters, you really want to look at it as a continuous variable. So we got it, so we looked at it that way. And we did univariate comparisons with non-parametric stats. We also thought it was important to control for confounders, so things that actually lead to an increased risk of having a complication. And so we adjusted for age, study site, your absolute neutrophil count, having low blood pressure but not severe sepsis, stem cell transplant status, and as well as central line type. Then, thanks to the reviewers, we did a number of sensitivity analysis, so that we ended up, I think, with 25 supplemental tables in this paper. So in order to really slice and dice it everywhere that we can. So we ended up looking at each site separately, only those who had a positive blood culture, which was 13.9% of the group, only those with non-severe hypotension, which was another 115 patients, only those that were presented inpatient versus outpatient, pre-2015, post-2015, looking at only the first episode in each person, using 90 minutes as a cutoff instead of 60 minutes, and also did a bias analysis and calculated e-values for potential unmeasured confounders. So if anybody can think of any other analysis, let me know, and I'm happy to do it, but we kind of went through the ringer to do everything. So looking at results, so those were presented unstable. So this was only like 0.6% of the cohort, and this was 14 patients who were severely unwell, basically people that showed signs of severe sepsis. And in fact, at both sites, we gave antibiotics really quickly. The TTA in this group was only 28 minutes, in the interquartile range 20 to 37 minutes, but had a very high mortality rate, 57.1% died. And this shows that these patients are recognized quickly and given antibiotics quickly, but even with giving antibiotics quickly, they can still have a poor outcome. So it's really important that when someone does present, I'm not advocating not seeing these patients quickly. Everyone needs to be seen and assessed. It just, if they look good, they don't necessarily need an immediate intervention. So baseline data, the median TTA of the whole cohort was 56 minutes. It was 48 minutes for Colorado versus 60 minutes from Vanderbilt. 54.3% received antibiotics in under 50 minutes. In Colorado, it was 75.2% versus Vanderbilt 49.6%. Before you say, okay, Colorado is so much better than Vanderbilt, the thing that I would say about this is that we used a lot broader time period. So if you actually look at the time period where we were targeting the metric, we were almost exactly the same as you all. But it was like back in the time before we did it, leads to the different results. You can still think you're better. I'm just letting you know there is a caveat to it. Okay, so major complication and time to antibiotics. So interesting, major complications were more common in the group that got antibiotics in less than 60 minutes. And so down in this table, you can see that, the major complications was in 4.7% of those getting antibiotics less than 60 minutes versus 3.5%. But then when you made those adjustments that I talked about, it kind of took the significance completely away. So the p-value for a complication within 7 days is 0.98. So it really showed no association at all. But interestingly, there were no associations between time to antibiotic greater or less than 60 minutes and a major complication at any time point in unadjusted or adjusted analysis. We also found no associations between time to antibiotic and any complication at any time point in the adjusted analysis. In non-adjusted analysis, we found that ICU admission was more common in less than 60 minutes, both at 6 hours and 24 hours, and receiving bolus fluids was also more common in less than 60 minutes. All sensitivity analyses revealed no associations at any time point in the adjusted or unadjusted analysis. The only exception was in the Colorado specific data, so only looking in those 429, intubation at 24 hours at 7 days, but not at 6 hours, was associated with TT over 60 minutes. However, there were only 6 intubated patients in that group, whereas there were 11 intubated patients in the Vanderbilt group that had the opposite direction to it, and so that's why I think that that's probably a spurious finding. So looking at TTA as a continuous variable, there was no association between TTA as a continuous variable at any outcome at any time point in the adjusted analysis. And non-adjusted analysis, again, several things were more common with giving antibiotics quickly, due to that potential triage bias. All sensitivity analysis revealed no other significant associations at any time point in the adjusted or non-adjusted analysis. Again, that same finding was in the Colorado at 24 hours and 7 days with intubation. They also had a small association between the amount of IV fluids and a prolonged TTA. In the Colorado, there was a p-value of 0.049 in that direction. So if you're really looking for evidence, that's your evidence versus the overall evidence the other way. So the bias analysis showed that an unknown confounder of at least 1.5 would be needed to impact the results. So it would have to be a pretty strong one. And so in conclusion, we thought there was no clear evidence that reduced TTA improves clinical outcomes, and so should not be used as a quality metric. I initially presented the data as an oral presentation at ASVO 2022, and this was discussed by members of the U.S. News and Report Physician Advisory Board, and we now have been successful in getting it removed as a metric from U.S. News and World Report. So it is no longer a metric as of now based on this data. So why does it matter? So the metric was leading to inferior care. It was stupid to give IM ceftriaxone without a blood culture just to meet a metric, and so those things can be stopped. But, the question is, why not just adopt another metric such as 2 hours? And I would say that we didn't really find that any specific metric time was significant, and that really the goal is more to target optimal care. And that, there is time if a patient is well appearing to obtain a CBC result and decide. And then if people are ill appearing at all, then we always give antibiotics in quickly. So I would say a limitation is that this was all done in high income settings. Antibiotics were immediately available, and so we really need further study to really know if you can use it in more resource limited settings, because there's actually some evidence that maybe it does matter for some other reasons that I could go into later. Okay, so that's time to antibiotics. So then this leads to my next question of, do all pediatric oncology patients who present with fever and an ANC greater than 500 need empiric antibiotics? So when I started this journey, more than 10 years ago, the things that we all know is true is that we know that pediatric oncology patients are immunosuppressed from therapy. They all have, a lot of them have central venous catheters that are increased risk of infection. We know that if your ANC's over 500, though, a lot of times you have the ability to fight an infection. You have neutrophils that can go and fight. And there was little previous data to really guide us. There was one paper published in the previous 10 years before my first one that really made an inconclusive result. And so as we know, antibiotics can lead to resistant bacteremia and mess up your microbiome. The ceftriaxone that's commonly used doesn't cover many of the concerning causes of bloodstream infection like Pseudomonas, Acinetobacter, Stenotrophomonas, some of the Citrobacters, Enterococcus, uniformly doesn't cover MRSA and only covers about 11% of co-ed negative staph. So you're really not getting that great coverage that you really think that you're getting. However, because there's no standard, it leads to great variation. So by far, the most common management across the country is ceftriaxone, and then discharge home is the most common strategy. However, most of Canada, and there's some U.S. sites, Children's Laureate in Seattle, and used to be here, prior, and it's debatable. In some cases it is, and in other cases it's not. Give no antibiotics unless there's concern for severe sepsis. And, if you talk to the Canadians about it, well, why don't you publish your data? They say that they don't have bad outcomes and they don't need to publish it. And so that's why they never did. So, but yet most of the U.S. is not doing this. And so some centers even admit all patients for 48 to 72 hours, regardless of ANC. And which isn't great. So my first paper was a development of and validation of a prediction model for bloodstream infections in febrile non-neutropenic people with cancer. And so this started as a retrospective analysis of 463 cancer patients diagnosed between 2007 and 2010, treated at Vanderbilt. We ended up with 932 episodes of non-neutropenic fever with a central line. We followed IDSA rules for determining contaminants and then reclassified contaminants as non-bloodstream infections. The inclusion criteria is they had to have a fever. We define a fever as a temperature over 38.0 sustained for an hour, or 38.3 for any duration. Had to have a CBC in place and an ANC over 500. We excluded episodes that occurred within 7 days of a previous episode, people already on empiric antibiotics, or people within 30 days post-stem cell transplant. So a couple definitions is we defined high-risk BSI as ones more likely to cause complications. So this is like gram-negative organisms and Staph aureus. Fever was defined as the highest temperature within 24 hours prior to or within an hour of the initial blood culture. And severe neutropenia was assigned as an ANC under 500. So in order to make a model, it's important to design on the variables a priori, and we did that. They had to be available within 2 hours of presentation and have a biologic or clinical plausibility of being related to the outcome. So then this is my most stats heavy sentence, so I'm just going to read it, and then later if anybody wants to talk about it, I'm happy to go into detail. So we used a logistic regression model, used a penalized maximum likelihood estimation and a covariance matrix estimate by Huber-White, and conducted 300 iteration bootstrap validation. So we're happy to go into more detail later if anyone would like. All right, so then the results. So we had 932 episodes. So the BSI rate was 9.7%, which is actually higher than what we see in newer data sets. And it was back then that we used to put Hickman lines in all of our sarcoma patients due to continuous anthracycline. And so when we got rid of that, that really notably lowered the risk. In this particular cohort, only 45% of the isolates were sensitive to ceftriaxone. There were 25 contaminants reclassified as non-BSI. There were 2 deaths in the cohort, but neither from a bacterial infection. One was fungal, one was flu. And ceftriaxone was given over 90% of the time, but there were no deaths from bacteremia. And so because it only covered 45% of isolates, it was interesting that there weren't people decompensating or dying despite not getting empiric antibiotics that were appropriate. And this suggested that immediate empiric antibiotics may not always be necessary. So looking at the multivariable analysis that the model's built on, the strongest factors that we found is having a Hickman line relative to a port is almost like a 13.79 odds ratio. So, dramatically increases your risk. PICC line over port increases it. There's certain drug exposure that if you get high-dose cytarabine or dinutuximab within 24 hours, that we know that causes fever, that's actually very protective against this being a bacteremia. So if you put that odds ratio the other way, it would be 12.5. Having a higher temperature, so the higher your fever is more associated. Having hypotensions or chills is associated with it. Younger age is slightly associated. Having a higher neutrophil count, you get that classic left shift that kind of increases your risk, whereas monocytes kind of goes the other way, and then upper respiratory symptoms also decrease your risk. And then stem cell transplant ended up having almost no effect, and we'll talk more about why that is. And then there's these 2 variables that I'm going to talk a little bit more about that we've changed in later versions of the model. Okay, so then to look at a risk prediction model, the things that we have to look at is first at something called discrimination. So discrimination measures the ability of a model to differentiate between patients with and without an outcome. And the classic way people do this is a Harrell-C statistic that shows the discriminative ability of a general linearized regression model. And it's equivalent to the area under the curve of a receiver operating curve. So I think most of you have probably seen those. And, and it's a sensitivity versus 1 minus specificity curve. It ranges from 0 to 1. So 0.5 is really a coin flip. It has no predictive ability at all. In general, we think 0.7 is pretty good, over 0.8 is pretty great. And if you're less than 0.5, you need to reverse your thinking because actually going against your prediction actually does better. So if you ever get one of those and it's below 0.5, then you're doing something wrong. Okay, so here's the initial curve. So, so this showed a C-statistic of 0.898 with a bootstrap corrected of 0.885. And I have that here, and it did even better for high-risk bacteremias at 0.919. We converted this into a web-based module that I'm going to show you more about later. But then, interestingly, this is a kind of a distribution of where did all the predictions fall? And in fact, if you look down here at this 0 to 10%, so set was 711. So this is actually 74% of the cohort had less than a 10% predicted risk. And the actual bacteremia risk in that group was only 2%. And so you can kind of see a risk stratification. Then in an intermediate risk, there was people with a little bit more risk of bacteremia. And then at the high end, the numbers get really small, but they have a very high risk and with it. And so you can kind of see maybe low risk, intermediate risk, high risk. And you'll kind of see how this plays out as we move to the next steps. So some of the limitations, this was retrospectively collected. It was a very good EMR, but limited by what's in the chart. In particular, it's really hard to classify symptoms. So in particular, chills can just be feeling cold before you get a fever, all the way up to shaking rigors that could be, actually septic shock. And so in fact, if you looked at people that just reported chills in the chart, but had otherwise a predicted risk of less than 10%, there was only one BSI in that group. And so, prospectively assessing that is a lot easier. We think that all ill-appearing patients who are not clinically stable should always be treated with antibiotics. And the goal of any model would be to aid and not replace clinical decision-making, but at that point lacked both prospective and external validation. So this led to our next paper, which was a multi-site external validation of risk prediction model for diagnosis of bloodstream infections in pediatric febrile pediatric oncology patients without severe neutropenia. So this was published in Cancer in 2017, and this was a 6-site external validation site where we had previously published data sets from Stanford, Brown, and Lebanon that we used, and then had a non-published data set someone gave me from Columbia, and then had some friends from CHOP and UCSF who pulled together some episodes. And so we ended up with 1197 episodes. The BSI rate in this group was 6.3% with it. This is probably the most embarrassing part of my talk anytime I give it is that, up until the point we'd always called the model just the model, and I didn't really see the need for a name for it. But then when we start talking about validation of things, then you do have to call it something. And so I wasn't good at coming up with a good acronym. So someone from Stanford just said, well, just call it Esvan for Esbenshade Vanderbilt. And so I ended up doing that. But in fact, I ended up naming the model after myself. And so now it is called the Esben model, and in one of the papers, they made me write it out in the title, like the full name, not because they said I couldn't have an abbreviation in the title. So it does make me look very arrogant, to name something after myself. But I'm just saying it was somewhat accidental. Okay, so interestingly, when we went to externally validate, we did reconsider some of the variables. And so one variable we had in the original model was ALL diagnosis, which was actually lowering the prediction risk. But when you really look at the data, it was really driven by ALL in maintenance and not ALL like in DI or in relapse setting. And so it's really inappropriate to give a lower risk to someone who's actually in a higher risk setting. And so in fact, taking that out as well as taking out patient location, presenting inpatient or outpatient, actually notably improved the model. And so that's why we have this Esvan 2 version that now exists. Okay, so then when you get to putting a risk prediction model into a new setting, you also, in addition to just looking at a disease statistic, you need to look at something called calibration. And so calibration measures the agreement between observed outcomes and actual predictions. And so it's assessed graphically with a calibration plot, and it has the predictions on the x-axis and the actual outcomes of people at that level, what they actually ended up having on the y-axis. So a perfect prediction should be on the 45-degree line. So if it goes straight there, what you're predicting is exactly what's actually happening. And so curves that are above the 45-degree line functionally underpredict outcomes, and when it's below the line, it over-predicts. And so what we found was, the C statistic did fall a little bit to 0.733, but then it was still really good for high-risk BSI at 0.841. But interestingly, the calibration showed almost a perfect calibration in risk under 20%, and then tended to overpredict a little bit. But we actually thought overprediction actually isn't a bad thing, because you can have culture negative sepsis or severe infections that mimic BSI that you still want to cover for. And you can, anytime you calibrate, you can recalibrate it and force it to be the slope to be 1. But what it causes it to do is causes you to underpredict at the high end. And so we didn't think that that was a smart thing to do. So instead, we left it where we understand that it's really pretty perfect initially, but then it maybe gives you a little bit of overprediction at the high end. But that's not a bad thing. Okay, so again, that same breakdown is this time 85% of the cases were in that less than 1% group, had about a 4% bacteremia rate, whereas the high-risk group, again, had a higher rate. So again, you can kind of see a lower, intermediate, and high risk. And then this led then to our next thing, which was actually a prospective implementation of a risk prediction model for bloodstream infections that can safely reduce antibiotic usage in febrile cancer patients without severe neutropenia. So this was published in the Journal of Clinical Oncology in 2020. It was based on the strength of our own data. And so we implemented this model in April 2015 and collected data through August 2019. We still use it to today, so we have data going all the way through now. But in order to do this, we created a standard operating procedure of all pediatric oncology patients treated at Vanderbilt that had a central line in place. We excluded patients under a year of age, people with a history of an allo stem cell transplant or within 30 days of auto transplant, as well as people already on empiric antibiotics at time of fever. So when a patient presented to the ED clinic or inpatient or even an outside hospital, embed inclusion criteria, if they're well appearing, once the CBC was back, we would enter it into the model. And this would either be done by our oncology physician, fellow, or MP. So on call, if it was through the ED, it would be the fellow on call that would enter it in. And then we would save it in. And then we would use the model to determine a prediction. And so we used the regular Esbenshade model until 2017, when we found out that the Esbenshade 2 was better, and we switched to that at that point. So management was guided based on risk. So if your risk was less than 10%, we would discharge home without any empiric antibiotic and told to return if you worsen in any way. If you're intermediate risk, 10 to 40%, we would give a broader spectrum antibiotic better than ceftriaxone, usually either levofloxacin or sometimes cefepime, piperacillin, tazobactam, and send home to return. And then if we thought if your risk was actually over 40%, we really probably shouldn't be sending you home. And so we would admit those patients on cefepime for at least 48 hours. So some of the special circumstances, if your ANC was under 1,000 or quickly following, we always gave antibiotics. If you had signs of severe sepsis, so you had severe hypotension, shaking rigors, mental status change, all of those patients get antibiotics. If we also would treat any other bacterial process independent of BSI risk. So if you have otitis media, or you have strep throat, or you have pneumonia, there are ways, as pediatricians, we work up all of these things that you really can't have one model that predicts all possible infection. And actually, what ends up happening is it works against itself, and you really get no predictive ability. So this is really to predict just symptomatic BSI, bloodstream infection in particular. So we let model enforcement always up to the treatment provider. The recommendation wasn't followed. We just got them to enter the reason why it wasn't followed. It's actually helped in the long run of getting people towards implementation, because I privately gathered this information and then sent it to attendings that weren't doing it and showed them their reasons for choosing other things and what the actual outcomes are. And it actually converted everybody. But I did it privately, not as public shaming, because if you public shame, they would dig in against it. But if you do it privately, it actually can have the desired effect. So the episode duration here was 937 episodes, 88.9% were low risk, 8.6% intermediate, and 2.3% high risk. So you really see it's not many patients you would need to admit in this kind of scenario. So in 834 low-risk patients, empiric antibiotics were successfully withheld in 78.9% of cases. Some of the non-compliance reasons include 54 people because we gave cefepime before counts were back in order to try to meet the time to antibiotic rule. That only led to one true bloodstream infection, or 1.9%. So that probably wasn't a great reason. 18 patients were thought to be ill-appearing but were low risk by model, and so there were 3 true BSIs, so like 16.3%. So that kind of does give credence significance to, if someone looks really ill appearing, to go ahead and give antibiotics to them, because no model's going to be able to predict it perfectly. 52 other reasons antibiotics were given for other reasons that led to no true BSIs and 2 contaminants. So 73 patients were given initial oral antibiotics to cover strep throat, otitis media, pneumonia. So it ended up being 70.1% that received no antibiotics at all on day 1. And looking at 7-day post-presentation, 72.2% never received an IV antibiotic or treatment antibiotic in the whole month, the whole 7 days. And there were no deaths or ICU admissions that resulted from withholding antibiotics. So looking at bloodstream infections in the low-risk group, there were some real bloodstream. So there was someone that grew Pseudomonas, Synotrophomonas, Enterobacter coliaceae, and MRSA. But interestingly, they were almost all afebrile in all but one case, and in all cases were well appearing upon representation. So we would call them back in, and they're like, well, I'm doing great. And then we would put them on antibiotics because we have it. So it shows that this isn't magic. So I can't predict all BSI, if you have almost no symptoms, but I think it's really good at predicting those who need immediate intervention. So looking at the outcomes of higher risk, for intermediate risk, the BSI rate was 13.6%. 10 of those were sent home and were all afebrile and well appearing when their culture turned positive. And for the high risk group, the BSI rate was 54.5%. All did well with empiric antibiotics and hospital admission. So all versions of the model did well with a C statistic over 0.8. Specifically, Esbenshade outperformed Esbenshade 1, but we still needed external prospective validation, and so then this was initiated. So in order to make implementation practical, we created something called a web-based module, and this is you can just search Vanderbilt risk prediction and it comes up, and it's a way you can enter the data, and then after it's entered, you can use one-way only API to save the information directly into an institution-specific REDCap database. And so basically a collaborating site, after they capture their event, just enters the 4-digit code and hits save, and it saves the data automatically in. And then they can share de-identified data back with me. This is what the model looks like. So you can, if you search Vanderbilt risk prediction, on your phone, you'll even see it. You can click on all the different things. The patient location and ALL is still on here, but it actually doesn't impact the result because it uses the Esbenshade. But if you enter all of those things that were in that original model I showed you, it'll generate you a prediction, so like 6.2%, and then give you a confidence interval. And then this is where then you can select your site. So you can see there's a lot of places, including you all, that's already set up to be able to do this. And then you can enter in PHI, so like actually your name and medical record number, and then hit save. The reason for that is so that people can go back and validate it. None of this data hits a Vanderbilt server. It only saves directly, securely into a REDCap database, and so we've been able to get that through all the IRBs. So then this led to a recent paper that was a prospective external validation of the model, so I had to have my full name in it instead of Esvan, accurately predicts bloodstream infection risk in febrile non-neutropenic fever with cancer. And this was published in JCO in 2023. It was an 18-site study. We got 2,565 prospectively collected episodes. Again, Leonora and Jenna were part of this, and so actually the second biggest cohort was from Children's Hospital of Colorado, so we do have good data from you all. Complications were rare in the cohort. Only 1.1% needed ICU care. All-cause mortality was only 0.2%, with only 1 infection-related death. And that person did, in fact, get empiric antibiotics. Initial antibiotics were withheld in 14.9% of cases. These were largely people from Seattle, Stanford, Children's Lurie, and Colorado while you all were still doing that. And there were no deaths or ICU admissions due to not receiving empiric antibiotics. Again, the calibration curve looked almost exactly the same, almost perfect prediction at the low end with a little bit of overprediction at the high end. The C statistics were all, close to 0.789 was the best performing one, but all of them performed pretty similarly, all versions of it, and did even better in predicting high-risk organisms over 0.8. Again, the same distribution. So you see that the low-risk group this time was 86.9% of group, only had a 2.4% bacteremia rate here, whereas, then you kind of have an intermediate and high risk. 3.2% of the people were high risk, and so again, small numbers that we really would have to admit. And so it really shows that the model, I think, is reliable across sites. And along with the Vanderbilt data, it showed that there would be potential safety to implement this at your site. And so I always like to say to people, for oncologists, that I'm happy to set your site up. And actually, you all are even already set up. If you wanted to use it, it's already there and ready for you. It's easy to be able to access it. And you can always collaborate with me on future studies, but it's completely not required. You fully own your own data. And the only time I get data is if you share it with me in a de-identified manner. So then the question about stem cell transplant is, we found that the model doesn't work great for allogeneic stem cell transplant in particular. And so this was published in Cancer in 2023. We did an allo-based model, and we actually found auto transplant, it really works great. And so it holds up pretty much across the board. But an allo transplant, it was a little bit lower, 0.678, so that was the first time I was really going below that 0.7 in discrimination. And in fact, there were some low-risk cases we were missing that actually had pretty significant infections. And so what we found out is that you needed to adjust for immune suppression. And if you do that, actually, the model actually worked really well, and it notably boosted everything up. However, we're still needing external validation for this. So I'm currently recruiting sites. I have about 12 on board so far, where we're trying to fully validate this and see if we can get a version that holds up. We're also adding on a version that's looking specifically in patients that have their with transplant patients who have their central line pulled, because a lot of them are still at pretty high risk. And so we're trying to establish the risk there. A lot more that, I can sort of answer questions about and always talk about, but, we are working on some models for severe neutropenia. Our goals with that is trying to find people that can go home from the ER safely and oral antibiotics, that people that potentially could go home after 24 hours versus staying for 48 hours. So that's hopefully coming soon. We have a lot of other exciting things on the horizon. So if you have any specific infection-related questions, happy to answer and tell you where the field is and where we're going. But thank to a lot of people, specifically here at Colorado that have been greatly helpful to me, have been Jenna, and as well as, previously Leonora, and then Halden Scott on the ID side. The fellow Kenji Tanaka has helped me with the tumor lysis project at Vanderbilt, which was also that we're putting out, that is actually really interesting data as well, where we've been able to really scale back our management there on that. So if you have questions, that's my email. I'm on Twitter, though I don't know that I really want to be. With that, and that is for the evaluation. And so I will open it up for questions. Go ahead.
Our catchment area is so large, will patients present it? Sorry. My question was regarding inclusion, whether sites included patients who didn't present to their campus ED. Our catchment area covers lots of rural areas. We have patients presenting to smaller EDs or adult facilities. And were you using this sort of assessment scale based off of an outside provider's assessment, or was it only for patients presenting to the main pediatric institution?
Gotcha. No, it's a great question. Actually, what I've been talking to a lot of your colleagues about in the individual meetings with it. So yes, the Vanderbilt data, we have about a 3-hour catchment area. And so anytime that with the outside data, we could get the necessary variables for abstraction, we included outside hospitals. So in time, I didn't show you the exact numbers, but yeah, there are quite a few episodes that were captured both in that time to antibiotic as well as in all the model building over time we have. When we did the multi-site, there were a lot of other sites, similar to you all, that had people from far-reaching areas. So so at least showing that the model accurately predicts infection, I think is true at outlying situations. I think the key is, is good communication with those outside sites and kind of figuring out how to operationalize. And so been strategizing with meetings with different people about how you all might be able to do that. Yeah, go ahead.
Really great talk. Thank you. Were there factors that you found in your modeling that were surprisingly predictive, or conversely, things that you as a clinician would expect to be predictive that were not found to be in the model? One of the thoughts that I have, seeing this work is that in many ways, some of these factors like hypotension and rigors and things, it feels very much like a formalization of the same things that I was taught as an intern, as a general pediatrician, of this is what sepsis looks like. So I'm curious if you found surprising things one way or another as you were actually looking at the predictive value of any of those individual things.
No, that's a good question. So yeah, the biggest thing that was surprising that now it's been validated in multiple papers is really the effect of central line in non-neutropenic fever, that having a Broviac or Hickman line is a dramatic risk factor, that it's almost like a 13-fold increase over a port. And that's really where you get a lot of those surprising bacteremias that you might otherwise think are going to be low risk, that it ends up upstaging people pretty good. I mean, where it counteracts it is in you're getting dinutuximab and high-risk neuroblastoma. That's a very protective thing. And so if you put those together, then it kind of cancels it out. So I think that the reason for using a modeling type thing, so you could just do well-appearing patients. I mean, I think that it does help to have some quantitation to it. It's an easy way also to capture the data. So if you actually want to monitor what's happening by saving it, then you kind of know what happens in the long run and then can improve it. I think that there are some cases, so particularly with central lines, where there was a patient that we weren't going to treat. Basically, I was standing next to the fellow and I asked her to model it, and then the patient actually had a 45% risk and then grew gram-negative rods on the way to our hospital from an outside hospital. And it was because it was a kid with a high fever and had a left shift, but no chills, hypotension was fine, but had a Hickman line. So I think it gives a little bit of extra safety. It also helps for just sites that aren't open to just doing it regularly to have some kind of support behind it. So, and actually with families, we've had no family ever fight us. When I say you have a 1.2% chance of bacteremia, none of them say, well, but I want antibiotics anyway. So I think that is where it helps too. So. But yeah, I mean, there are programs, evidently, Toronto does it without any kind of stratification to it. But I don't think they capture their data to know when they're failing, those bad actors. And so far, by using the model, we haven't had any failures of someone coming in and dying as a result. Yeah, go ahead.
Okay. I have a very naive question. I'm curious about the use of ANCs for the inclusion and exclusion criteria. I read something in regards to there are some people who have neutrophils that simply camp out in the bone marrow, while other people, they dispel them out into the peripheral blood. And so I'm curious on how that could impact your interpretations on whether to give the antibiotic or whether to give another treatment or not give a treatment. I'm just curious if you had any thoughts on that.
Yeah, no, that's a good question. So there is something called benign ethnic neutropenia, where some people have just a lower set point, so then they may even sit with a low ANC just normally, like you just routinely check their neutrophil count, it'll be lower. However, when people get fever, they demarginate. And so even those patients out of the bone marrow, even if your resting neutrophil count is this, it's not that they don't have adequate neutrophils in their bone marrow, they just don't sit in the actual bloodstream. And so when you get infections, they all come out. And so if we usually say then in a stress situation, then if your ANC is under 500, you don't have the neutrophils adequate to be able to fight the initial infection. And so in general, then we have this whole febrile neutropenia thing. Now it's really continuum. The lower it is, the higher your risk is. So when your ANC is 0, some of those patients we even keep admitted to the hospital, because if they're going to be down there for a long time, and we put them on prophylaxis even to prevent infections. But I don't know if that kind of makes sense. But then when patients are over ANC 500, they have the ability to fight. And as long as they have those frontline fighters, that usually keeps them from getting decompensated quickly. And so then that's what kind of buys us the time to do the assessment and then make decisions. Sure. Other questions? Go ahead, Adam.
Thoughts on, if we are going to get patients and then we
And do. Yeah, so actually, we've changed about 2 years ago at Vanderbilt our policy that, and really, we didn't lead the way. Really, the UK and the national health system kind of led the way in 2019. But what we basically do is, if you're afebrile and have negative cultures at 48 hours, we stop empiric antibiotics without count recovery, and we generally watch them for a day and then send them home, and they've done well. You know, that really there's already good evidence in the adult form in doing this. We tried to do a COG trial to actually prove this, but then when we actually surveyed sites, we found out that only about 50% of COG sites still keep people to count recovery. And so that it really wasn't going to be feasible to doing it as a trial. Now, different people do different things. You know, so there are some people that send home on oral antibiotics, which I think actually leads to overexposure to antibiotics, because a lot of times they don't assess them again for a week. And so I think, you know, stopping them completely, you know, this whole idea of watching them an extra 24 hours, they don't do in the UK, but that's what I had to kind of give into to get parsimony within our group to do it. But we did it, you know, August 2023, I guess is when we put it in, and it's gone really well. So I think it is a safe thing to implement. We are working on a COG trial, potentially looking at this in a stem cell transplant as an idea. So there's some transplanters interested in it. So we'll see if that ends up having the legs to do it. But don't have data for that, but general oncology, I think it's safe. Yeah, go ahead, Sidra. Hi. Yeah, so if y'all talk about it at the level of that y'all want to implement it, it is already set up for you all. So Jenna has access to the database, and you can use the model now without having any kind of database. You know, you can just search Vanderbilt risk prediction. It'll give you a prediction. But if you want to save the data so that others can go back and look at it to make sure nothing bad happened, then it's a way to easily capture it with it. So that's why we save it at our site. Go ahead.
That you have started in August, is it all diagnoses?
It's not stem cell transplant, so it's
But
all
AML or high-risk ALL?
Yeah, no, so that's a good question. Yeah, so for the AML or people we traditionally keep in, we do have the same process, but we put them back to levofloxacin and prophylaxis as opposed to taking them off everything. And we don't necessarily send them home. So we keep them, like if there are people that we were going to keep in-house to count recovery, we still keep them in-house to count recovery on prophylaxis as opposed to sending them out.
Okay, so just switching to levo while they're.
Yeah, just going back to levo prophy for those people at highest risk.
And what about like ALL and DI or?
Yes, because that isn't a group that we hold in, so we have successfully used it. We could pull our data. I mean, those papers are actually somewhat hard to publish because some reviewers will say, well, that we already know this, and that it's not that helpful, you know, to do it. Because I told one of my friends from Children's, Larry, to publish her data, and ended up not getting into pediatric blood and cancer, and went all the way down to JPHO because the reviewer said this isn't new news. And it's like, but yeah, you know, I still think getting the data out there is important.
Practice changing, even if it's not new news.
Correct. Yeah. So I think it's important to get the data out there. And so we do plan to show our experience, but you know, 2 years of data is, and I like bigger numbers. So I like to probably wait till we have more substantial numbers, and then we'll likely put it out. Yeah, go ahead.
Also, sorry, those patients typically also have a Hickman or a Broviac, right? So are
Yep.
they kind of like in a middle risk group, would you say?
Right. Yeah. So when I say using the model, applying, you know, it can be a high risk group. You can still use the model. They're just going to have a higher predictive rate. So if you look at the auto transplants, they do more commonly get into that intermediate risk where they need antibiotics, but it's just that using all those variables classify them correctly. And we just found in allotransplant that it wasn't always classifying people correctly. Whereas when we added the immunosuppression, it did as well. Now, of course, it's a little more complicated doing transplant at multiple sites, and this is what I'm learning in our current validation is we also, different people use different T-cell depletion techniques and different things that we also think impact it. And so we're capturing more than just immunosuppression and really looking to see if it holds up across sites. So, but that's to come. We have got a lot of interested people, so hopefully we'll get to a cool answer. Go ahead, Kitchi.
Yeah, thanks for the talk. I was wondering, over the last couple of years, like some of the more like kind of surprising or traumatizing patients are the patients that present with like typhlitis and then like die in like the first like 24 hours. But like traditionally it's thought that you can really only develop that less with like severe neutropenia. But in your model, was there any like abdominal symptoms that were included in like as part of like the clinical presentation or anything like that?
Yeah, no, we've definitely captured all that. I mean, you don't get typhlitis and non-neutropenic fever, thankfully, so we've never had anyone that's had a poor outcome on that side. In severe neutropenia, we capture it, but usually if they're going to be decompensators, they're going to die quickly. They also have other severe symptoms, that would clue you in. I mean, there are, the abdominal organisms that truthfully scare me are the Clostridiums, like Clostridium tertium and perfungens. I mean, like patients can go from looking fine to dead within 24 hours, but I don't know that actually, our patients that have had those have been inpatients, who got antibiotics immediately. And so sometimes even quick acting in that situation doesn't make a difference.
Yeah.
It's a very difficult situation that thankfully happens rarely at this point. Great questions from everyone, though. Thank you, everyone. Okay, so do I close it? Okay, all right, thank you, everyone.